And welcome back to Moving Conversations. I'm Brian Ritchie. Joining me as always is Nora St. John. Morning, Nora. How you doing?
I'm very well. Brian, how are you? I understand you're under a heat dome. They call it a
Oh
heat
my
dome.
gosh. I just took a small little walk, and from the time I left to the time I got back, it was weltering. It must have went up 5 degrees, and we're supposed to
Oh,
get,
Lord.
without heat index, over 100 to like 103. With heat
Oh,
index, they're expecting to be well over 110, maybe hotter than that, 115. So we'll see. Things change here
oof.
and there, but that's what they said yesterday's news. And I went, yeah, I'm not leaving the house. I'm going to stay home. I'm going to stay with the air conditioning on. I pray it doesn't break. It's one of those things. It's just like, okay, let's hope here.
I grew up in LA, right? So I always think that growing up in LA was kind of funny because the summers could be pretty miserable. And when I was growing up, it was also really smoggy. So I
Mm,
actually spent more time inside in the summer, like
mhm.
rather than in the winter. So the whole thing about hibernating is like, oh, no, no, I'm outside all winter and all fall and some of the spring. And then summer was like, and you go out, you do your thing, you come back in and you hang out until the heat wave goes away, which is just a backwards way of thinking about things.
I've always wondered why my parents decided to move from Colorado, which was already warm in the summer, to Phoenix.
Oh, yes,
And
they must like heat and dry
no,
heat.
the opposite. They really don't. It was just one of those weird things that air quality and all of that, it made sense to move there. Okay. I said, wait a minute. It's going to be 120, 120
Yeah,
degrees.
in Phoenix
And maybe
is.
that's on a good day. I mean, people usually
Uh,
just go out first thing in the morning and then wait until the sun goes down. So I said, are you sure? Oh, we'll just stay inside those days. I'm thinking that's most of the year, isn't it?
I
I
was
mean,
going to
that's got
say
to
that's
be,
pretty much May to October, if I remember Phoenix. Yeah,
yeah,
no, that's nuts.
exactly. Exactly. I remember we were there for an event in beginning of April, and one
Yeah,
day was beautiful. It had a
yeah,
little light overcast. It was gorgeous. The next day was already 90 degrees. And I thought,
yeah.
"Oh my gosh, and it's April. I'm about to go back to to the East Coast where it's going to be in the 40s. How do you stand all that heat?" And yeah, and we have the humidity here as well. So we're
Yeah, you
supposed to
do.
go to a baseball game Friday night. And I just said, you know what? No, I don't think so. My family doesn't do well with, warm temperatures. I don't mind them nearly as much. I'm not comfortable, but I don't mind them. Rest of them are like, no, no, thank you.
It's your Hawaiian blood. Oh,
Exactly. Exactly. So I just said, it's not worth being miserable sitting there sweating and just so it's like, nope, we'll stay inside, we'll rent a movie, we'll watch something, we'll chill
nice.
out
You'll have
because
a chill, and literally chill out.
we'll have to because there's nothing
Yeah,
going on outside. We talked about that thinking, oh, what are we going to do this weekend? Little as possible. That's what we're going to
yeah,
do. It'll be
absolutely.
office
Yep,
work, I have a feeling.
yep. It's going to be inside. Hey, I
Yeah.
have a little bit of an announcement. I actually have a website now,
Awesome.
norastjohn.com. So, and it includes everywhere I'm presenting and everything I'm doing. It also includes links to our show and all of our past episode, a little document that has a lot of that in it. So, if you're interested in that, feel free to come up or sign up for the being on my contact list or any of that kind of thing.
Fantastic. Fantastic. And do us a favor, hit the like and subscribe button. We really appreciate it. It helps the algorithm, whatever the heck that means. But what it basically does is help us to spread the word a little bit more. It gets us out there to more people. It's always interesting. I get to see the analytics, and some shows hit very well, others have a miss. So the more you can comment, the more you can like, subscribe, do all of those things. We really appreciate it because it does help us out a lot. Check out the YouTube page under my name, Brian Ritchie, and also check us out on Instagram at Moving Combos, or you can email us at movingcombos@gmail.com. So last couple of weeks, we've been talking about hip replacements primarily.
Yep.
And a
We
topic
started
that
with
came up a couple
oh, this
times
one.
was,
Yeah, yeah, yeah.
was not just the rehabilitation aspect, but also the prehab of it. We spoke with, like you said, Beth a couple of weeks ago, and the topic came up about prehab, and it did last week. And I thought, why don't we sort of continue on with practical application of rehabilitating hips, hip replacements, but also focus on the prehab because that's something that is really being shown to be more and more useful and more effective with our clients.
And there's two key things I want to bring up about that. One is that oftentimes, and you and I both had that have both had that experience. Clients come in with hip problems, and
Mhm.
they're saying they are preparing for or considering a hip replacement, and then you work with them for a while, and it turns out that really they were just deconditioned, and
Mhm.
that essentially just exercise and movement were enough to move them out of enough pain to basically put off that hip replacement indefinitely, or certainly
Yeah.
for a longer period of time. And as you know, you and I have both talked about, and we've certainly said on the show, the longer you put off those replacements to a certain extent, the better, because they don't last forever. If you've got somebody in their 50s or 60s who's thinking about a hip replacement, you kind of do want to put that off if you can. 70s and 80s, a little different, but certainly 50s and 60s, you want to really give them the opportunity to make the changes and manage that pain a little bit differently through movement and strength, so they don't have to have the hip replacement or don't have to have it so soon.
And something to think about. I had a client come to me, 5, 6 years ago. I think it was right around the beginning of COVID, maybe middle, something like that. And came to me and said, I need a hip replacement. Now, he's younger than I am. He's in his early
Mm.
40s. And I said, okay. And I'm trying to get out of him why. Could it be a structural issue? I've had a couple people who need it because of
Yeah.
structure. Sure. Okay. That's the only
Yeah.
thing that's going to get them out of pain. Sure. I've had many dancers. I've had people who have had, large bouts of prednisone. There are reasons to have it. Sure. But I was trying to get that out of him. And finally he said, well, I was doing yoga and I was doing a real wide split sort of thing and leaning over, trying to increase my range of motion because he had some back problems and was trying to do yoga to, supplement that. And he said, and my hip began bothering me. It began bothering me, and it got worse and worse and worse. And he's a little bit of a hypochondriac, just a little bit. Okay. He tends to focus on these things. So he
Mm.
went to see a doctor, and the first thing the doctor said, yep, it looks like you might have a labral tear. I think we need to do a hip replacement.
Whoa,
And I
that's
thought,
a that's
that's a
a
big jump. That's a
that's a
that's a
big
leap.
jump. Yeah, it's a big
That's a
leap,
big, yeah, that's a big leap. And what the
especially
doctor
in somebody
said
that
was,
age.
yeah, he looked at the MRI and said, well, it's too big of a gap. It would basically, they'd have to go in and just separate it and all of this. And I said,
Hmm.
when is it scheduled? And we had, I think, 3 or 4 months. I believe so. I think it was in August, and I think it was going to be late December or something. I said, fine, give me 3 months. I said, you can cancel it at any time. You can always cancel that, but I got to make you as strong as possible. But let's see how close we can get you to pain free before that. And if we can, and you maybe can put it off until it starts bothering you again, maybe that'll give you an extra 5 years, 10 years, whatever. And within a month, his pain went from being, in his mind, a 7, 6, 7 to being a 1. He barely noticed it. And
Mm.
then after a while, he just said, yeah, I don't even think about it anymore. Should I still have the surgery? He asked me this.
Right,
And
like,
I
no.
looked at him and I said, so what are you trying to solve when you have no
Yeah.
pain? He said, yeah, that's kind of what I'm thinking. I said, you can always call the doctor back. I said, trust me, he will book that.
Yes.
He felt bad. Oh, I made the appointment a long time ago. I said, trust me, he'll book it. I said, these
Not a
doctors
problem.
have a waiting list.
Especially if he's booking that far ahead. Right.
Exactly.
Then clearly
Exactly.
it's not a problem. He can fill somebody in that spot and no problem.
In a heartbeat. Exactly. And so he put it off. And that was, like I say, years ago, 5 years ago. And he graduated from me to just working out on his own. He checks in from time to time, but he's basically doing whatever he wants and doing fantastic and has no issues. Got back to playing softball and baseball again, sliding, all sorts of things, and has no issues. So it can be done. And oftentimes it's just doing the right things and strengthening the right way to really see if we can get the mechanics right and take pressure off of the area that may be causing the issue. So it can be done.
Yeah, I had a client who she was a hiker, like a professional guide for hiking up in the
Mm,
Sierras. And if any of you ever hiked in the Sierras, a lot of times you're literally walking on granite. It's a pretty unforgiving surface. And then
yeah,
you've
it
got,
is.
a backpack on, a 20 to 40 pound, probably even higher because she's a guide, 50-pound backpack on. So it's a lot of force.
Yep.
And her hips were killing her. both hips actually. It's kind of bilateral in her case. And then, and she'd gone to a doctor. She was probably in her late 40s, early 50s. She was not that old either. And they said, well, we're thinking about a hip replacement. So it was interesting in her case. It didn't take very long. Like she came in, we just did footwork, feet in straps, a little bit of abduction, adduction work, like nothing fancy at all. But she came in, I think, 3 times a week for about a month. And even after that month, like her pain was gone. Then we kept working, and I think this was in the winter, so she wasn't in her hiking season, because she was afraid too that she'd have to like change her job. She couldn't do her job anymore. Like it was a big major life thing. So we had about 3 more months of just working, just getting her stronger, getting her more resilient. Then when the next season came along, she was right back out there, able to hike, 15, 20 miles a day with a backpack on. And she put that off, as far as I know, for years after that. So again, these are 2 very positive experiences. You may not have the same thing out there if you're teaching or if you have hip issues, but it's something to know, especially if somebody hasn't done a lot of very specific hip stabilization and hip mobility training to kind of get things balanced.
And I'm going to preface it by saying this. I had that client, but I also had sort of the opposite person. He was in his early 50s. He went in to get it for a hip replacement or to talk to a hip doctor because he was having anterior hip pain. And the doctor said, you need a hip replacement. And he said, I'm too young. No, no way. And I even looked at the x-ray. He had a misshapen head of his femur. It was like an egg. And he had ground the center of the acetabulum so that it was bone on bone. I mean, I looked at it and saw this and I said, I'm sure that's what the doctor saw, because I'm not a physician. So I'm thinking, I know that's what the doctor's looking at here. And I said, did he mention anything about a misshapen femoral head? Again, I'm not going to give him any advice, but I saw it. And he said, he said something about that, but no, I think there's something else. So he went to another physician who said, oh, no. Your hip pain is caused by your low back. You need to have a spinal fusion.
Oh, God.
He chose to have a spinal fusion and he didn't need one. Yeah. I mean, and that was the whole thing was he having some nerve pain? Yes. And I said, please get a second or third opinion, but he so badly wanted to put off the hip issue that he immediately jumped to the spine.
God, you'd rather have a spinal fusion than a hip replacement? Okay, that's just not knowing what the differences are.
Yeah, and I mentioned that. I said, look, this is not something to just jump into lightly. And he did it. I saw him afterwards, and it took a while to get him back into decent shape, but the hip pain never went away. And he went to doctor after doctor after doctor, ended up at Johns Hopkins, maybe. He ended up at Mayo Clinic. That's where he ended up, Mayo Clinic.
Okay, yeah.
First thing they did was take a look and say, oh, you got an egg-shaped femoral head. You just have worn down the cartilage. You need a hip replacement. I mean, it was that apparent. And he called me and said, did you see that? And I said, so did your doctor. I said, I asked about that. He said, oh yeah, I guess so. I mean, he really wanted to avoid that. And I don't know if it was just because of the fear of a hip replacement. Maybe he had a relative. I never went that deep into the reasoning why. I'm sure there was a reason. But for him, that's what he needed. And had he had that done first, he probably could have put any spinal issue off for a long time because his core was very strong. He wasn't having issues with that. So there are some times in some cases, I've had a number of people who either through, like I say, drug interaction, that their bones have just worn down, severe osteoporosis. I've had a couple people who were severe bulimic and anorexic who basically wore down their bones to the point that they had very little in way of bone support and fractured their hip and needed to have the replacement. So I've seen a bunch of people who are younger who have needed it. Yeah. But my thought is, let's try the exercise first, because some people have just never exercised properly before.
Right. And I think of one other client I had who had rather severe hip dysplasia, where just meaning that the femur and the acetabulum don't fit very well, or the acetabulum is very shallow. So this just super unstable hips. And she had a hip replacement pretty early on, like I think in her late 30s. But she needed it. Like there was nothing, her hips were not holding together without it.
Yep.
But that all being said, even with that, even when they need to have surgery and that's the right thing and that's a good choice for them, then it's like, okay, so let's prepare them for that. And in some ways, it's pretty basic. You want to get
Mhm.
three-dimensional strength around the hip. You want to get three-dimensional strength around the knee. You may want to work on gait. You certainly want to work on their core in order to just get them as strong and capable as possible.
Yeah. I find that you said it earlier with the word mechanics. There are some people just by the way they stand, their hips jut out and the femur heads are riding forward in the socket slightly. And when we say forward, we're talking about millimeters. We're not talking about, a huge amount of
Yeah.
slack. We're talking about it's just pushing forward. So maybe their hip isn't sitting as well as it should. And just getting them into proper positioning, getting them proper exercise, something simple. I mean, the exercise I started with that one gentleman, literally hands and knees. Let's just have him do hip circles on hands and knees, just tracing like a silver dollar. And just let that leg hang for a moment. And then let's just start doing some simple circles, something simple. And again, what that was teaching was that the joint was going to have a little bit, the weight was going to pull it slightly out, just slightly, so that he had greater range of motion, greater freedom. So he wouldn't be, if there's any grinding, and just retraining how to do those movements. And he said that was
Yeah.
one of the things that made such a huge difference. And it was something so simple and didn't really require
Yeah.
much.
Yeah. And for all my clients, it's feet and straps, which is the same kind of deal.
Oh, I
Feet
did
and
that too
straps.
with
Yeah, either on the reformer or on the trap table. I
yep.
know one gal who I was really prehabbing specifically. She was actually a forest ranger, so she was used to hiking a lot. So again,
Mhm.
hiking seems to be a theme today. And for her, it was like we would just go onto the trap table and do leg slides. And I would have,
Mhm.
first we just do leg slides, and then I'd add a strap around her knee going behind her. So she had a little bit of resistance into her hamstrings. Then we do some leg slides with a little bit of resistance. We do some adduction, some abduction, and basically we started with that. And it ranged. It didn't
Mhm.
hurt and didn't increase your symptoms anyway. Not that it didn't hurt, but didn't increase your symptoms. And that was that's where we started, and then slowly built up to footwork, and then slowly built up to feet and straps. With more weight on the end of the lever, basically.
Mhm.
And again, she had much, much, much improved response. And she didn't put off her hip replacement, but she had a much quicker recovery than I think she would have before.
Yeah. Yeah. The thing I've noticed that one of the rules I follow, especially when it comes to someone who's pre-hip replacement or even pre-knee replacement, when we're doing prehab work or trying to see if they really need it or if they just need to exercise it properly, is trying to de-weight the joint as much as I can. Okay,
Yep.
because standing often bothers them. If they have a
Yep.
labral issue, it can be that it's pinching into the labrum. Whatever it is, if they are bone on bone or whatever, sometimes just getting the pressure off of it can really alleviate a lot of the discomfort. So trying to stay within that pain-free range of motion, especially at the beginning, gives them, first of all, a lot of confidence that what we're doing is not going to hurt them because they've been
Right.
in pain for a while. So just showing them, hey, this isn't going to bother it too much. And if we find a range of motion that does, let's change the angle, because even something like clamshells, 45 degrees from the hips may bother it, but 90 may not, or 30 may not, 60 may not.
Exactly.
Find what doesn't hurt and train the heck out of that angle. And you can
Exactly.
still gain strength.
Yeah.
And again, hands and knees, feet and straps, all of these sorts of things. Sometimes I would just have them stand on one block on a step or stair that I teach them to do at home. And much like doing a pendulum for the shoulder, where we just have
Yeah.
have to be
Exactly. Just
pulled
let the
out,
legs swing, right?
just
And
let their
swing in
legs
little
swing.
circles.
Yeah. And I'll say, first of all, just use your other leg to sort of let it swing. Don't kick your leg back and forth. Just use the other leg to just sort of let it dangle. Just
Yeah.
dangle. And they say, oh man, that feels pretty good. Great. Now, maybe let's draw an alphabet with that leg. Small, make it very, very small. Now, maybe circles, infinity sign, whatever you want. I mean, it really doesn't matter.
Yeah.
But eventually, now you're asking the muscle to work, but it's moving in small ranges of motion. It's not compressing the joint, and it's able to get a little bit of that stability. And again, working with them in a way that doesn't cause them more discomfort or pain, lets them trust that they can work out without pain, but also lets them trust in me and in us that we're not going to make the situation worse and hurt them, so that they feel, oh, okay, and they're willing to try a little bit more rather than closing off and I can't do anything.
Right, absolutely. And one of the things I always think about with that, and I'll say this to them when they say, "Well, this doesn't feel like much," right? Because oftentimes I'm doing pretty light work with them,
Hmm.
but again, light work, somewhat unweighted, or at least so that joint isn't jammed up against itself. Is I say, look, muscles are designed to actually hold the joints slightly apart. Right? Like that's what the knee muscles do. That's what the hip muscles do. That's
Hmm.
what the spinal muscles do. If they're working appropriately, they allow you to just very slightly decompress the knee joint or the hip joint so that it can move smoothly and freely in that socket without bumping up against itself.
Yep.
There's a million studies that talk about people who have arthritis, even kind of bone on bone arthritis in the hip or the knee, and how many of them are actually in pain and how many of them are not.
Hmm.
Right? Same situation, same pathology, same wear and tear on the joints, but one group is able to manage that and even be comfortable with it, and one is not. And a lot of times it is that strength, three-dimensional balance strength around the joint.
Yep.
Sometimes to your point, I liked what you said earlier about that what I think of as a posterior tilt, shoving those femurs forward.
Hmm.
Right, that's kind of a very typical, I find very typical issue that can lead to hip pain over time. Because
Yep.
again, those femurs just gonna push slightly forward, pushes into the labrum, pushes into the tendons that run along the front of the hip joint, push into the joint capsule. And more than once, just changing that posture, stick your tailbone out, shift your weight
Hmm.
slightly to the front of your feet, and practice that makes all the difference. So
Hmm.
again, posture, balance, not causing more pain, those are all really key pieces.
Yeah. That really trying to establish that pain-free range of motion is a great place to start. And then
Yep.
trying, when you said working three-dimensionally, we've been talking about that, you and I, for how many years have I known you? We've been talking about doing that because it really does train in all planes of motion, including rotation and really getting the body to move properly. I had a gentleman who, when I say needed a hip replacement, by the time he got the x-ray, he had a severe cavitation on his
Um,
greater trochanter. He was missing 2/3 of it. It was
oh,
almost gone. The
wow.
ball itself had deteriorated so much, but he had almost no pain for the longest time
Wow.
because he had developed enough strength. And it really
Yeah.
didn't bother him, to the point that when I saw the x-ray, my first question was, "How are you walking? How can you?"
Right.
It just, and even the doctor said, "I don't know why you weren't in here 5 or 7, 10 years ago,
Yeah.
because it's unbelievable." I'd seen him for 15 years by that point, but it was a lot of just keeping him strong,
Yeah.
working range of motion in ways to keep him three-dimensionally strong, and he was in his 70s, early 70s at the
Mhm.
time. He did great, and eventually it was
Wow.
sort of like, "Oh, okay, this is what I need," and when we saw the x-ray, it was sort of, yeah, there's no choice." It really
Yeah.
was that clear cut. It's sort of, "Okay, you've put it off for as long
Yeah.
as you can, and
Let's give
now,
you
eh,
let's replace
I
your
gotta
part,
do it."
man. Your part
Yeah,
is done. It needs to be replaced. Yeah.
exactly,
Interesting.
exactly. But again, what it shows on an X-ray, you and I have seen this many times. When you look at an X-ray, we can usually see when something's bone on bone because that nice black area that shows the separation of the two bones is no longer there, and it kind of looks like it's fused together, one solid piece of white. But we've also known people who have had that in their knees or hips where they don't really have any pain. They've gotten an X-ray for something else like a tendonitis, tendinosis, and that's just the first step of the process. And you look at it and you think, how are you walking on this? But they don't have any pain. All it takes sometimes is the thinnest microscopic layer of cartilage that can't be seen on an X-ray to still give you protection. And
Yeah.
you don't have that bone on bone pain.
Exactly. Exactly. One other thing, which I'm sure you've had clients like this, and I think about one particular person whenever I think about this. One of the issues that I've seen a lot, and this is where I work on, this is what I work on with prehab and post-surgical as well, is the compensations that people get into
Yeah.
from pain. Because again, I've had a lot of clients, and I'm going to think of this one instructor particularly, who really put off a hip replacement way longer than they probably should have. So
Yep.
by the last really 3 or 4 years I would see them, they were literally not flexing that painful hip much at all. So they would walk by taking one step and then lifting that whole hip up, shortening that QL on that right side, and then putting that foot down. And then basically that was their gait. Very little hip flexion was happening because I'm assuming that was what was causing pain. And that was the other thing that I like to work on or notice with somebody who is coming in for prehab or also ideally prehab through surgical and afterwards is what are the
Mm-hmm.
compensations that are
Yep.
happening that I may need to work on? Because that was interesting in her case is after the surgery, I saw her and she was still having the same compensation.
Yeah.
Like her gait
Yeah.
was a little better, but it really wasn't as much better as it should have been, given
Mm-hmm.
her situation and what she knew about the body and all that. So I was like, those compensations can get really wired in because again, it's just the body reacts to what it reacts to. So the other thing too is looking at what's happening with the core. Look at what's happening with the quadratus lumborum, with the hips, with the piriformis, with the hip flexors, with the
Mm-hmm.
hamstrings. Like who's trying to do the job? Because a lot of
Yes.
times, as you go through that, you'll just see, oh, they're trying to do all of this with their, in this case, for QL, right, lifting that hip
Yep.
up. It's all happening from
100%.
or they're not doing any flexion, so it's all happening kind of from the knee, right? The knee is doing all the work. So it's all, or they're walking, they're up on their toes or something. There's all kinds of funny compensations you'll see, and a lot of times for me, I also look at and just try to see what that is. What are they doing that's possibly taking them out of pain, but causing other trouble in the process?
And that's the issue. You said to yourself, getting them out of pain. Pain doesn't always happen overnight. Sometimes, yes, you have a trauma. And sometimes I tell people it's the straw that broke the camel's back. You've had this issue for
Yeah,
so many years, and finally, the last little straw, and they have pain. But a lot of times, they've been avoiding pain. I can tell you
right.
right now, my knee's bothering me because I went on a long walk when we were in Chicago. My arthritic big toe started bothering me, and I started circumducting my leg in a funny way. I caught myself. But guess what? I can't tell you if I did it for 5 minutes, 30 minutes, 3 miles. I couldn't tell you how long I did it for when I caught it. And again, I'm a movement professional. So for me to catch it, I thought, wow, okay, what about our clients who don't know what's going on in their body? Thousands
Yeah,
upon thousands, millions upon millions of repetitions are being done the incorrect way, the wrong way, overstimulating a muscle, over strengthening, like you said, a QL, especially. We see that a lot with hip hiking. That QL
hmm
becomes so tight and so overly strong that even when they do have the hip replacement or knee replacement or whatever they need, you're still going to have to deal with that. That's going to become an issue. So if you spot it before the surgery, I highly recommend start working on that immediately because it's something that's going to be addressed eventually. You may as well start now.
right. Bouncing out the core. So for me, a lot of lateral flexion, a lot of rotation.
Mhm.
In the torso, a lot of just basic core work, a lot of back extension work, a lot of abduction for sure, because that's oftentimes where, for many people, that's where hip stability is the weakest, is in
Mhm.
abduction. And
100%.
I've had with a lot of my hip replacement clients, I've had to start really, really small, like
Mhm.
tiny isometrics with, let's say, the ring around the thighs or a band around the thighs, and just gently pressing out and holding it in kind of a basic seated position. And then we
Mhm.
slowly build that up because sometimes even that, just that slight pressure out, will cause pain or discomfort. So just finding what they need to work on in terms of getting those areas loosened up and stronger.
Abduction, we've talked about this in Pilates. It's underutilized in Pilates, and I think it's underutilized a lot in fitness in general. Although I
Yeah.
will say this, in the last probably 5 years or so, I'm seeing more people doing things in gym environments. I travel all over. I see a lot of different gyms, and I see people doing much more
Yeah.
lateral work, and I'm thrilled. I have to say, I'm
Yeah.
thrilled to see that because it's so important, and it was what was missing for so long. We were so sagittal in everything we did that we really didn't worry or work on our lateral plane nearly as much, and rotational. Forget about it. Hardly anybody did any of that unless you were into sport specific things. But to work the abductors is so important. That glute med is so critical for walking. It is so critical for balance. And
Mhm.
it is still, I think, underutilized a lot in our older clients because they go with what feels comfortable. They go with what they've done for so many years. And we really need to introduce those to them and make sure that they're doing those motions and getting them strong. And like you said, start easy, start very basic, don't overload, or else they're not going to be able to walk. And sometimes you'll cause other issues.
Right. So starting with just like isometrics, as we often do for a
Yes.
beginning stage, isometrics in various different angles, and then slowly working into sidestepping with no resistance, and then with bands, or then the reformer, standing work, or standing work that you guys do, I know with cables and things like that. So playing with that is for sure it. The other thing too that I've played with, and this is what I really love about feet and straps, is working the hip in different angles.
Hmm.
So we often think about flexion and extension, right? That's what walking is. That's what most of us spend most of our time with our hips doing, seated, standing, seated, standing. But what we miss is we miss adduction and abduction, and we also miss rotation, both medial and lateral rotation in the hips.
Hmm.
And one of the things that they say about arthritis is arthritis can be both an overuse and an underuse situation. Meaning, if we never stimulate the joint in certain areas, it can also become arthritic. I mean, we often
Hmm.
talk about it as being, wear and tear, which it certainly can be. But if people never medially rotate or never like cross the midline in terms of their adduction, then they're not stimulating a certain part of the acetabulum. And sometimes that can also lead to a bit of arthritis. So again, whenever I'm working with them, I play with, let's play with parallel, to a little turned out, to a little turned in. And then things like feet and straps, like if I'm doing circles, and this is, I have to credit Valentine, my good teacher friend Valentine, for this. She'll basically have people draw different things with their legs with feet and straps. So she'll
Nice.
do like snowmen, right? So you're going to kind of doing like three little circles, one on top of the other. Or I do what I call spirograph, where they take little circles and they start with the legs together, draw little circles out, and then little circles back in. Because one of the things I've found is to get hip stability, you want to challenge it in a whole bunch of different, somewhat unexpected angles.
Yes.
Right, not just straight side, forward, back, even just external, internal rotation, but how do you find all those little in between spots, which is often what's missing, and that's a lot of times why there is hip pain, is because they're missing some
Hmm.
critical piece of the support system in there.
Yeah. Something that I've worked on with people. First of all, I love that. The idea of drawing different figures and all of that works so well. The spirograph really works well. It really shows our generation and our age though, because I don't
I
know
know.
how many younger people
I
really
have to show
know.
my hands. I have to use my hands to go like make
Absolutely.
little circles out and little circles back in, because they're like, "What do you mean? What's a
Absolutely.
spirograph? What are you talking about?"
But it's true. That really does get it. I'm going to throw something out here that I do with a lot of people, and I haven't seen a lot of people do this, but I think it's important, is if you're having them do something like standing up and sitting down, if you're having them do something like squats, even footwork on the jump board, or, a leg press that you're doing more like a squat, vary the foot position a lot,
Yeah.
but make it asymmetrical.
Yeah, I played with that too.
A lot of people will always want to make it exactly symmetrical. So you may say, take your feet out a little wider, and then they're perfectly balanced. Take them out a little wider, and they're perfectly balanced between the two. I'll have someone start marching, and I'll say, stop. Okay, now squat. And you can see that their brain wants them to change their foot position. I say, no, right like how it is, just like this. Oh, I say,
Nice. I
how
like
many
that.
times have you gotten up off a chair, off the
Yeah.
toilet, something,
One leg
and
turned out,
one leg slightly turned out,
right?
one leg slightly turned in,
Yeah.
one foot slightly forward, one slightly back,
Yeah.
whatever it is. Rarely are
Yeah.
we perfectly symmetrical.
Yeah.
And it's the same thing with push-ups. The same thing with anything that we need to when I'm in contact with the ground or a wall or whatever. Change the
Nice.
foot position and make it variable, because that's real life. And those changes are going to change how the joint mechanics work. And again, it's just making it more real life. It's taking that from the fitness environment, the gym environment, the Pilates studio environment, and putting it into real life and giving them something that they can do that It doesn't have to be perfectly symmetrical, perfectly balanced left to right, because rarely are we.
I love that. I love that. One of the things that I learned, possibly the hard way, because I tend to learn things this way, was I was teaching short box abdominals. Okay, so
Mhm.
reformer, like you're sitting on the reformer, you're sitting on a box, your feet are under something, and you're basically rotating, and this is the rotation work. And what I found there that was interesting to me was that I had a reformer class Monday, Wednesday, Friday at 8 o'clock for years. And so this was my guinea pig group. And they would basically do, let's say, roll back into a small curl basically, and then rotate side to side, just straight rotation with some flexion. And they would do that, let's say do that for 2 or 3 weeks, just that version of oblique work.
Mhm.
Then let's say I'd say, oh, let's change this up. So then we would do something more like around the world, where you start side and then you kind of rotate up all the way around the other side and then back. So you're getting different angles of all those oblique abdominals essentially, and how those are working. And what I found was whatever we had done, like let's say we did just a straight rotation for 3 weeks. If I
Mhm.
went and then did around the world, it was as if they hadn't done it before.
Yes.
And they had, because like we've done this a million times. So it really, really drove home to me how we get good at exactly what we do.
Yes.
Like, yeah.
Mhm.
And that's kind of what we're doing with the hip work, is if we can play with, let's not just do it one way, because we don't live one way, right? How do you just like change an angle, or change the angle with the feet in straps, or change the hand position? I love that, because that's really where our body learns to stabilize in unexpected ways.
Yes. Correct. That's so important in everything that we do. We want to make it unexpected. We don't want it predictable, because life is not predictable.
Right.
I'm going to throw something out there that I know you do, but I think a lot of people don't realize this. I think we have biases when it comes to the
For
human body,
sure. For sure.
and we get something stuck in our brain,
Yeah.
especially, my specialty has been especially post rehabilitation, but low back, I spent many years studying it. Well, tight hip
Yep.
flexors are always part of it. Tight hip flexors, tight hip flexors. But if all you do is stretch them and you never strengthen them, you're creating an imbalance. If all you do is strengthen the glutes, strengthen your glute med, glute min, but don't ever address the hip flexor, you're
Yep.
creating a huge muscular imbalance. So I
Yep.
find that there's a lot of people who sort of get
Mm.
these thought processes in their brain of, oh, tight hip flex, oh, that's bad. Hip flexors are bad. We want to avoid working those. No, 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 no. You actually want to strengthen them. We need to strengthen every muscle, because a weak muscle is often going to be a muscle that's tight. Not always a muscle that's overly shortened or overly tight is super strong. A lot of times it's the exact opposite.
And going into the psoas with the hip specifically, right? If you think of
Mm-hmm.
the iliopsoas tendon, it literally runs over the ball of the femur and connects into the lesser trochanter on the femur. And one of the things that I certainly have seen and have experienced is if you're doing something like leg circles, which is a Pilates exercise where one leg's up in the air and you're making little circles with your legs, and there's a clunk, clunk, clunk
Mm-hmm.
at a certain point in that circle. Oftentimes it's one-sided, not both. And oftentimes that is that iliopsoas tendon popping over the front of the femur. So when I look at that and when I hear that, it's one of the few clunks that I'm concerned about,
Mm-hmm.
because I'm thinking that iliopsoas tendon is potentially rubbing over that joint capsule and that labrum every time they do that. And that same thing happens to some extent when they shove their femurs forward, that they're also putting pressure on their whole anterior joint capsule and the labrum of the hip. So one of the things that I think about, and this is just getting to your point with the psoas, is I want to strengthen the hip flexors, yes, but I specifically want to try to create balance in the psoas, both
Mm-hmm.
mobility and strength. And almost every client I know with hip issues has incredible imbalances in their psoas strength. And this is, again, I
Unbelievable.
know muscle testing is like a whatever slightly controversial thing, but if I just have somebody sit with their feet on the floor, they're at a roughly 90-degree angle, lift one leg up, and then try to push it down themselves, And they can do that on one side. They try the other side, usually the injured side, and it's like they have no resistance there.
Mm-hmm.
That's a kind of a very simple, basic kind of muscle test for the psoas. And a lot of times that shows me that that injured hip psoas is super, super weak. It may also be tight, but it's super, super weak. And, you know, I want to balance the forces on the spine. I want to balance the forces on the hips. I got to balance some of that strength out.
And the position you were just explaining, where that tendon and muscle is riding right over that joint capsule. If we go into a traditional hip flexor stretch where we're just basically doing a lunge forward, what's happening? We're literally just stretching out that portion, and it's pushing right on that joint capsule the whole time, unless you put yourself into a posterior tilt, or you can sort of rock back and get to more length, through the lumbar spine to really get more of the psoas involved and get that lengthened as well. You're basically not getting a lot of stretch involvement, which is why so many people go into that lunge all the way down and they say, oh, I don't feel very much. But if you put them in the right position, they say, oh my gosh, do I feel this? It's like, yes, you don't have to go into a deep, deep lunging stretch in order to do that. But I agree 100%. Even if you just have a client sit at 90 degrees and have them just march.
Yeah, exactly. I do that a lot.
10 minutes, they're dying.
Yep.
And if they're injured on one side, oh my gosh, you'll be lucky to get that foot off the ground for more than a couple of inches. And what I do is I start lowering their seat. I love putting them in office chairs because I can start them up high, and then they can lift their leg. And they're often lifting just to 90. They're not lifting beyond that. And they think, oh, this is easy. Let's lower you an inch. Let's lower you another inch. Let's lower you another. And once we get to a certain point where they have to go above that 90 degrees for every repetition, you see how quickly they fatigue. And you can see just how weak their psoas is. Their iliacus is. That hip flexor as a unit is so weak. But in their mind, oh, I just need to stretch it. I don't need to stretch. I just need to stretch. That mindset is sort of stuck.
It's definitely stuck. And one other regression there that I've taken a few times with clients with this is I actually have them supine with their feet on the wall at 90 degrees.
Mm-hmm.
So they're still lifting above 90, but they've got gravity assisting, like in kind of a major way. And oftentimes for the psoas, I have to start that far back.
Yes.
To get it comfortable and to get them starting to strengthen. And then I'll slowly move them a little bit away. So they're starting below 90, through 90, and up above 90. And then we slowly work up to seated, et cetera. But a few times I've had to go that far down the chain in terms of a regression to really get that hip flexor starting to work especially on the injured side. It's just so common there.
What I have sometimes done for an assessment, if someone is arguing with me, because there are some people who do get it stuck in their head that, no, I don't want to work my hip flexor. I need to stretch it. I'll say, okay, let's just do a simple assessment. Okay, I'll take a step, put it at 12 inches. And they look at it and say, that looks really high. So we're not stepping up on it. Just take your foot and tap the top, and then tap the top, tap the top.
Yeah. Nice.
And easy. About the third or fourth one, they kick the step. And I go, ooh, okay. And I put it back. I say, keep going. And eventually they're having a hard time getting it up and over that. They're kicking the step. I'll do this with a ball as well. I can put a soccer ball and say, just tap the top lightly. Tap. And after the third or fourth repetition, they kick the ball. And I say, well, you better go get it. And then they go get it, and then they try it again and they kick the ball. I say, oh, wow. I say, see? I said, it may be tight, yes, but there also seems to be a lack of strength. And I think we can increase your flexibility and mobility by increasing the strength of that muscle as well. And when you explain it to them, you sometimes have to show them and demonstrate them to them in a way that they can see it.
Yep. Yeah, that whole idea that something, because Pilates too has some of that bias of don't use your hip flexors, don't use hip flexors, don't use hip flexors. And sometimes how I describe that is you want to think about the hip flexors in a more complex way, ideally, for all of you out there. So not just like as one giant group, which you can think of them as, but I like to think of them individually. So we've talked about the iliopsoas. The thing I think about is the rectus femoris, which is our major quadricep hip flexor, our sartorius, which will also do external rotation and abduction, and then our tensor fasciae lata and our gluteus minimus, which do an internal rotation and abduction or flexion, and then even our some of our deeper adductors. So what I often find is those are also imbalanced. We've talked a little about the
Hmm.
iliopsoas, and one thing that is kind of a, well, I'm not sure it's an easy assessment or not, but if you watch somebody walk towards you, you can often see, especially if they're running, but walking you can sometimes see it too. Does that leg track straight ahead? Does that knee and that femur track straight ahead when they walk? Does it track in lateral rotation, or does it track in medial rotation?
Hmm.
And again, you can't always see that in walking, but you can certainly, every time somebody runs, if any of you are like me and like to watch runners do their thing on the trail near us, I always am intrigued by what's happening. You'll see it immediately, because when they go faster, the second that leg comes off the ground to go into that stride forward, it'll either stay straight, which is, I think of being more rectus femoris dominance. It'll laterally rotate, which is often external rotator or sartorius dominance, or it will internally rotate, which is our gluteus
Hmm.
minimus and tensor fasciae lata dominance. And so sometimes too, I can look at that and see what is their strategy in hip flexion, and try to get them to change that, modify that. And a lot of times that is working on the psoas and working on getting that rectus femoris to do more of the job, because it's often the one that will really track it the straightest.
Yeah. Coming back to the whole working in 3 dimensions, I really want to sort of put a point on this and make sure that everybody really understands what that means, because even in something like hip flexion, you don't just necessarily have to have it come straight ahead. You can do some
Right.
external rotation. You can do a little internal rotation. And if you find that one is lacking, you can focus maybe a few more repetitions or an extra set on that side. So, really taking a look at every single motion and trying to figure out what is their weakest. The one that I bring up all the time to, especially when I'm teaching Pilates instructors, is abduction. They're taught
Yeah.
to do it with their hips very stacked. Well, a lot of times, though, you watch it and their toes will turn slightly upward. And you can see that they're using a little bit more TFL. They're using a little bit more of the anterior portion of their glute med, and the anterior muscles, as I would say, are getting a little more than the posterior. And sometimes
Hmm.
you just need to
Yeah.
remind them to bring their leg behind them. Maybe put that hip and slightly incline, slightly make it go forward just a little bit, or to put the toe down. Just changing the position, and all of a sudden, oh my gosh, that's so much more difficult. Well, it's just an
Yeah.
area that you haven't trained necessarily as much. So we
Yep.
may need to focus on that just to balance it out. You don't want to just focus on one side and not the other. And I find that a lot of people go to whatever is their path of least resistance, and whatever they've been
Yeah.
doing is how they've
Whatever they're
always been
used
doing
to.
it.
Yeah,
Yeah.
absolutely. So abduction, and then you kind of mentioned it. A lot of times, the default is strengthen the glutes,
Hmm.
right? Like I always think of that's kind of where people typically go when they're working on the hips, is strengthen the glutes, strengthen the glutes, strengthen the glutes. Now, that's generally a good idea, honestly.
Yep.
Like most clients are not
Hmm.
that strong there, and I'm totally for that. Every now and then, especially some of my clients who are more athletic, more maybe anteriorly tilted or a little more lordotic, overuse the glutes, and that's
Hmm.
causing their hip trouble. And that's not so common. I don't know what the sort of proportions are, but certainly that's not as common as just weak glutes, but they're not always the answer. So that's the other thing too,
Hmm.
is just staying 3 dimensional. Is it hip flexion? Is it hip extension in multiple angles, right? If I'm thinking about doing, one of my favorite simple ways to do that is all fours leg lifts, right? All fours, just lifting the leg up. Um, and playing with that in parallel, playing with it turned out, playing with it internally rotated, taking that leg and lifting it up and then tapping it across the other leg, right? So back and
Hmm.
forth. So you're getting all those angles of that extension. And those are all, again, ways to 3 dimensionally train these complex systems, because they don't work in isolation.
Yeah, they don't. And that's something that again, we have a tendency to forget about. And I think it's missing in a lot of rehabilitation when people go through physical therapy. And it's a lot of times they just don't have enough time. They are
Exactly.
told, get this person walking and get them as
Yeah.
strong as possible in a shorter period of time as possible. And that's the insurance industry making
Yep.
those rules. So it's our job to really look at that. And sometimes I will tell the person when they show me what they've been doing, I can say, okay, you've been doing it this way for now. We're going to adjust this a little bit. I don't
Mm.
say that, oh man, what was your physical therapist doing? Because I don't know if they've mutated the exercise completely,
No,
or
I don't blame the
don't blame
messenger on that
anybody.
one. No, because
No,
I have no
because
idea.
we have no idea. unless we know the person, we have no idea what they've been doing and how they've adjusted it in the meantime. But I'll just say, oh, you're ready to take that next step. You're ready to move on.
Right.
And it makes them feel good. Oh, I've gotten stronger. Absolutely. Now let's roll your hip forward this way or roll your hip back, or let's focus on this, push through your big toe more, push through your little toe more. Small adjustments. And they'll say, oh man, I really feel this a lot more. I said, okay, we're going to do this for a couple of weeks. Then we change it up again. Continue to change things. One of my favorite techniques that I will use is I bought these dots. These flat dots you can put on the ground. You can get them really inexpensively online. Anywhere from, I've gotten 3-inch ones all the way up to like 9 or 12-inch ones. And I throw them out at different angles and they kind of look like twister dots.
Yeah.
And I will literally play twister with them in that I will say right foot red, and they have to find the red and then take a step toward it or lunge toward it or however we're doing it. And it'll be at a weird angle. Sometimes I'll have them go across the body because we don't often do that. But if you're walking and you want to take a step, do we often cross our leg into the other one when we're changing direction? Sure, all the time. So I'll call out across the body. I'll call out behind them and I'll say right leg, and it'll be, if they're facing 12 o'clock, their left leg, I'll say left leg, and really they have to go almost all the way to 4 o'clock. And they're like, how am I supposed to do that? I say, get as close as you can or find another way. And sometimes they'll go, oh, I can sneak it around behind. Yes, you can. All right. And you can see they have to use their brain. They have to figure it out. They have to sort of problem solve at the same time, but they're working their hips, they're working their legs in ways that they don't in a traditional fitness or Pilates environment, but how we use it in a regular everyday environment all the time. So again, I want to take that from exercise into reality as much as we can. And those are real cheap. I get a package, oftentimes I'll give them some. I'll buy the small 3-inch ones and I can get like 50 of them for $5 or something online. And I'll say, here, play with these at home, know?
And so one thing that I love about what you do, Brian, because I've seen you do a lot of these drills, and they're just, if you guys don't ever play with these, they're super fun. And a lot of times, like, again, this is getting maybe to clients that are a little not in the prehab stage, but maybe it is. They're really great to do at the end of a session. So the last 5 minutes, do a lot of standing stuff, stepping over things, stepping up on things, stepping at different angles. It just takes all the work you're doing, and I'm thinking of this from a Pilates perspective, on the machines, in the environment, and taking it up into a more challenging, oftentimes more practical position. So the other thing too that I wanted to just bring out about what you said is changing things up, because when we get really good at something, some movement, and it really doesn't take any attention anymore, we've gotten kind of as efficient as we can with that particular movement. We've stopped paying attention. Basically, our nervous system is gone. I got this handled. I can go on autopilot and start thinking about my laundry list, right? Or whatever it is.
Yeah.
So that's where shaking that up, giving new input, new stimulus, different order, more resistance, different angle, all those are really important to keep the brain, and I think the motor control system like active and running instead of on automatic.
And also, I'm gonna throw this out there for my people who have my type A clients who want to know exactly how many repetitions and how many sets before we ever start. And I just say, just keep going. What do you mean? Just keep going. You're not tired yet. But I did 12. Hey, you can count. Good for you. Keep going. It doesn't matter. The number of repetitions doesn't matter. If you're going to fatigue, they get used to doing a certain number.
Yes.
But if suddenly, I had a client yesterday, I've done this many times, when I'll say, okay, one more, and they'll do one more, and I'll say one more. And she looked at me and she said, you're not allowed to do that. And I said, yes, I am. Do another one. And then she did another one. I said, do another one. And she's giving me this evil look. She did 5 more repetitions before she got tired. And I said, see, you could do more than you thought you could. But if we'd stopped there, you wouldn't have pushed and you wouldn't have realized that. And you could see she was proud of herself. She was still a little upset because she really wants to know the number ahead of time. And I say, it doesn't matter. It's go until your body tells you, okay, I think I've had enough.
And the world doesn't give you numbers.
No, it doesn't.
I mean, if I'm like, I've been remodeling my office here. So I was doing like, sheetrock mud yesterday. Like it doesn't tell me, oh, I'm going to lift my arm up 4 times at this height and do this. Like that's not what's happening. Or
Nope.
I cook a lot. It's like it's not going to tell me I'm going to chop that carrot 17 times, 4 times in a row. Like that's not what happens. And if any of you have children out there or dogs, like that is an unpredictable situation.
Yep.
You can't count on I'm going to do 4 of these and 6 of these. Now I appreciate that, sometimes that gives you some structure to your workout, which can be helpful for sure. And I totally get that, but also understand like that's not what real life does for us. It does not provide us with the numbers ahead of time that are going to be required to do the job.
I remember she was a chiropractor friend, and I was training her to do like a Tough Mudder sort of situation. And we would go into the parking lot and do walking lunges. And, she'd think she was done at doing a certain number. And I'd say, okay, 20 more. And she would just look at me. And I said, you want to do an ultra endurance type event that involves running, jumping, twisting, turn, that's going to use your whole body in ways you've never done before. You think 10 more repetitions? And immediately she said, got it. And it changed her mindset because she had a goal oriented. Well, guess what? Life is goal oriented. We need to be able to do things. What if you have to carry something farther than you think?
Yep.
You have to be strong enough to do that or be able to put it down somewhere. What if you have to do something or walk farther than you thought you did? Well, guess what? You got to figure it out. Like you said, life does not give you a certain number of repetitions. I've done drywall work. It's not going to say sand this 12 times and it's going to be perfectly smooth. No, it may be 200 times. It may be 4 times and everywhere in between.
Absolutely. So I think this was hopefully this got you guys some ideas, right? We talked a lot about, I've got pretty practical here, a couple of case studies, and then a lot of just thinking about the hip 3-dimensionally, ways to get out of our habits of, don't do this, always do this, staying sagittal. Again, working with the hip, you want to make it as 3-dimensional as possible, really identifying where it's working, where it's not working. And oftentimes, as Brian said, and as Brian's experience and my experience, just by balancing those things out, sometimes in pretty simple ways, you may be able to help your client at least recover better from a hip replacement, or even put that hip replacement off for a period of time.
Yep.
So hopefully that's been helpful to you.
Yeah. And I think this gives you, like Nora just said, a lot of practical things that you may not have thought about before. Or I don't know about you, but a lot of times I've used to do something and it's, oh, I haven't done that in a long time. So hopefully we may have reminded you of something to do and be like, oh yeah, I guess I haven't been training my hip flexor as much as I used to. Maybe I should try that again. So even on your own body, maybe it's reminded you something that you can play with a little bit.
Exactly.
All right. Well, do us a favor again, hit that like and subscribe button. We super appreciate every time you do. Check out the YouTube channel under my name, Brian Ritchie. You can check us out Instagram, Moving Convos, or email us, movingconvos@gmail.com is the best way to get in touch with us. And for Nora St. John, I'm Brian Ritchie. We'll see y'all next week.
Bye, guys.